I'm really excited to be with everybody today. It's great to be doing this presentation with my colleague, Lauren. During our presentation, we're going to start by providing an overview of the Depression Center program. Some of you might be connected with our program already, and it's really great to have you with us today. Others attending may have family members or friends that you're looking for additional resources for, and it may be helpful to hear about what our programs offers. We'll spend some time talking about our psychotherapy team and treatment options within our program, and we'll then provide some information regarding what depression is, causes, and common depression symptoms. And we'll close with providing some information regarding how to be connected with our program, referral process, and offer some additional resources for support and have time for questions. So the Poul Hansen Family Centre for Depression is UHN's clinic specializing in depression and mood disorders treatment. And our program aim is for those with depression or bipolar symptoms to receive access to psychiatry and psychotherapy treatment approaches within one interconnected team, rather than having to connect with many different programs for services. So the first step that all patients go through when a referral to our program is accepted is to have a psychiatry assessment. During this assessment, the psychiatry team provides diagnostic opinions as well as treatment recommendations that may include medications or other treatments like brain stimulation. And later today, we're really happy to have a member of our psychiatry team and scientific director talking in more detail about the psychiatry aspect of our program and common recommended medications. So stay tuned for more information regarding this. And the psychiatry team will also assess whether psychotherapy treatment is indicated. And if interested, patients are then referred for an intake with a member of our psychotherapy team. So during the psychotherapy assessment, patients meet with one of our team's mental health clinicians, such as Lauren or I, and we review the patient's situation, challenges, and goals. Psychotherapy support within our program is primarily offered in a group setting. We'll also assess patients for additional short-term individual therapy support as needed, and may also recommend other community resources outside of our program that may be helpful as well. We run 3 main psychotherapy groups, and our groups are all virtual as we see patients from various places across Ontario. And our groups meet once a week for 2 hours. Our groups are skills-based psychotherapy groups, where the focus is on learning new coping strategies related to the group topic, practicing and discussing skills in group. And I'll now pass things over to Lauren to talk more specifically about the different psychotherapy groups we offer.
Thanks, Hannah, and thanks to everyone for having us today. So I'm going to take some time to talk about the various psychotherapy modalities that we provide through our individual and group work through the Depression Center. These are all evidence-based modalities, and they're not unique necessarily to our center, but hopefully going through these modalities will give you a good idea of the kind of work that we do, including the kind of techniques or strategies that we look at and the goals that we try to achieve collaboratively with the patients that we meet with. So the first one we can talk about today is cognitive behavioral therapy, or CBT. You might have heard of this one before. It's probably one of the most popular therapy modalities that's used. Our CBT group is a 12-week group, as Hannah mentioned. And what we do in our CBT group is try to look at the impact that our thoughts have on our mood, emotions, and behaviors. And as the image on the screen kind of suggests as well, kind of the interplay between those factors, how they can reinforce one another. And so through CBT, what we try to do is take a closer look at things like our thoughts, our underlying assumptions, and core beliefs that we might have about ourselves and about the world. The idea that when things like depression or anxiety are around, those thoughts and beliefs tend to be negative, pretty unkind, unhelpful. So trying to work with those to help lessen the symptoms of depression. With CBT, we also might examine how previous life experiences continue to maybe influence how we think and how we behave in the present day. And so with all of that, the goal of something like CBT is not just positive thinking, but rather landing on thinking that might be more balanced, more helpful, and more realistic. And usually it has an extra layer of being a little bit more positive as well to it. So if we're meeting with somebody during a psychotherapy intake and considering recommending CBT, we might listen for somebody who presents with struggles with like a really strong self-critic, for example, or maybe some of those negative thoughts come out almost as like statements, like I'm useless or the world is against me. So those are the kinds of things that we might keep an eye out for. An example of a technique that we might use in CBT is something called behavioral activation. That might be something that we reach for if somebody is having struggles with something like low motivation. And this technique is something that our colleagues Christina and Emily are going to share about more later today. Our next modality that we can talk about is dialectical behavior therapy, or DBT, also a very popular modality that is evidence-based. And so with DBT, rather focusing on our thoughts like we did with the CBT, we can really focus on the emotional side of things instead, especially those emotions that might be quite overwhelming. Maybe they seem random or out of control. Sometimes we say kind of like the emotions are in the driver's seat rather than us being in the driver's seat. So whatever those emotions are, they might get in the way of our ability to remain effective or do what we need to be able to do. So as the image on the screen shows, there's kind of like four different parts of DBT that we can go through in our skills group. We start with our core mindfulness skills. This really involves like gaining a better awareness of our emotional states of mind, being able to notice, describe, and observe what might be going on with our emotions, and better able to ask ourselves, now that we notice what is here, what can we do about it? And the subsequent skills that we go through in DBT can help kind of answer that second question. We then go into skills like distress tolerance, as the name kind of tells you, helps us to tolerate distress, get through pain, discomfort, or maybe scenarios or situations that are long lasting and painful. The idea with distress tolerance is that we want to be able to kind of get to the other side of those painful scenarios without feeling worse or making it worse through unhelpful behaviors. Some of our distress tolerance skills might include using the body to be able to do that, to tolerate that distress. Those skills that we can really reach for to work quickly to help get through that pain. We then go through emotion regulation skills to actually then change the emotional response that we might have to something that is upsetting. And then we end off with some interpersonal effectiveness, which can include applying some of these skills with interactions with other people, but also bringing in concepts like boundaries, assertiveness, and validation. So the goal of DBT is really building a foundation of these skills to help remain in control of emotions and work towards what we call in DBT building a life worth living. So something that is consistent with our goals and our values. So if we're considering recommending DBT for someone that we might be meeting with for a psychotherapy intake, we might listen for someone who might have some challenges with identifying their emotions, regulating those emotions. Maybe they feel quite disconnected from others and self, or acting in unhelpful ways. Along that line of kind of acting on unhelpful ways, sometimes when there's that strong emotion, there could be kind of a pull to act in a particular way. So one of the DBT techniques called opposite action can be helpful in those scenarios. And again, that's another technique that Christina and Emily will go through in more detail later today. Our third modality that we can talk about today is mindfulness-based cognitive therapy, or MBCT. Now, mindfulness is something we've probably all heard about or experienced in some shape or form. And it can be helpful and applied in a variety of different contexts. But MBCT specifically is an evidence-based modality developed specifically for somebody who might be living with depression or anxiety. And really the overall focus of something like MBCT is to try to prevent the return of anxious or depressive symptoms once somebody might be experiencing some improvement or feeling more well. So with MBCT, we want to try to build what we call kind of a non-judgmental awareness of the present moment, including things that might come along with anxiety or depression. Maybe that self-critic that we talked about earlier, physical pain, whatever it might be, those things that we might tend to kind of try to turn away from or not experience fully because they're painful. But the idea with MBCT is that we want to try to get a better understanding of how we habitually react to those things that might be painful, and then increase our ability to try to respond to those difficulties in a meaningful way. So we do that kind of through, this is an 8-week group, so we do that throughout the 8 weeks and try to wrap up with like a toolkit that one could take with them. So like, what are my warning signs? Is mood starting to shift? And if so, what can I do? So in our MBCT group, we do a variety of different mindfulness practices. Some might be quite short, like a 3-minute breathing space, or a little bit longer, like a 40-minute body scan, or somewhere in between. MBCT isn't often the place that we start because, again, it's supposed to be implemented when somebody might be feeling better, which isn't always the case when we're meeting somebody for the first time through our psychotherapy intake. But it can be a really excellent option after somebody, again, might be feeling better or has engaged in other treatments. So maybe somebody has completed a DBT program and has noticed an improvement in their symptoms. Maybe they've completed a round of RTMS or had some success with new medications, and MBCT can be a great way of kind of continuing that positive momentum. Final modality that I'll talk about today is compassion-focused therapy. I think it's fair to say that we probably sprinkle in compassion-focused therapy throughout our individual and group work, regardless of like the main modality that we use. But what we also do once somebody completes one of our treatment programs, they're eligible for a year's worth of monthly group booster sessions. So we use these booster sessions as a way of doing like some refresher of some of the skills from the other groups, but also to bring in some new skills, new perspectives through compassion-focused therapy. So we've already mentioned some of those things that can be really challenging with depression like that. I'll bring in that self-critic again. So using something like compassion as a way to kind of mitigate those things. So trying to extend kindness and compassion to ourselves and to others, and try our best to accept that compassion from other people as well. So these are the 4 main modalities that we provide in our work at the Depression Centre. And hopefully that gives you an idea of what we listen out for when we meet for somebody, and also kind of the work that we do when we start to do the work. I'm going to pass it back over to Hannah to continue.
Thanks, Lauren. And just noting the question in our Q&A, thanks for adding that. We'll come back to answer at the end of our presentation, and welcoming others to add questions as we go along as well. So in terms of the prevalence of depression, depression is a mood disorder that negatively affects how a person feels, the way they think, as Lauren noted, how you might act, can cause feelings of sadness, loss of interest in activities once enjoyed, and lead to a variety of different emotional, physical challenges, and decreased ability to function at work and at home. And we're going to talk further about symptoms of depression in a few moments. According to Stats Canada from 2022, almost 8% of Canadians had experienced a depressive episode in the past 12 months, and about 14% of adults will meet criteria for a major depressive disorder in their lifetime. And almost half of those with mental health disorders spoke with a professional about their mental health in the past 12 months. So really, these numbers show us that depression is more common than we might think, and also that there are many who may not be getting the care that they need for their depression symptoms. You might wonder about what causes depression, and there's many factors and components that contribute to how we're feeling and whether or not we develop a mental illness such as depression. And it's important to understand that depression is not a person's fault, and it's often not caused by just one thing. Depression can develop due to a combination of biological, psychological, and social factors interacting with each other. Someone may be more vulnerable to experience mental illness due to biological factors, for example, genetics, having a family history of depression. However, this on its own does not mean that someone's going to experience depression, as psychological and social factors also play a really big role. Psychological factors such as experiencing grief, significant stress, having limited coping strategies, or social factors such as lack of support during childhood or currently being really isolated could also increase vulnerability to depression. But we can also use these multiple factors that influence mental illness to our advantage. Although can't change our genetics, we may be able to improve biological factors through medications, for example, or change social factors through increasing connection with positive supports or strengthening coping skills. And psychotherapy support through our program really focuses on improving those psychological and social factors. And as we noted later today, some other members of our team are going to provide some examples of coping skills for managing depression. I'm going to pass things back over to Lauren to talk more about common depression symptoms.
Okay, yeah, so we've heard a lot from us talking about depression and what we can do about it, but we'd also like to hear a little bit more from everyone who's attending today. So, when you hear depression, that word come up, how do you think that you might go about defining that? Whether it's from what you've heard or experienced or wondered about, what kind of comes up when you think about defining depression? And I'm going to see if I can pop this into the chat here. So how would you go about defining it? It would be great if it could be kind of popcorn style in the chat. And as I said in the question, kind of maybe it's certain thoughts that you can think of or kinds of emotions. Maybe it's feeling it in the body in a particular way, or maybe it's certain behaviors. And I'm just going to stop sharing my screen for a moment to make sure I can see the chat as we do that, but encouraging anybody to share what comes up. So hearing from an attendee, so feeling like walking into quicksand, absolutely, yeah. Thank you for sharing that. Hopelessness, life becoming gray, not enjoying activities that previously might have brought joy, definitely. Lethargy. Feeling like, what's the point? Irritability and cognitive fog. Again, yeah, feeling like things are pointless. No sleep. Sleep's definitely a difficult one with something like depression. Give a moment to see if anybody else would like to share what comes up for them. Harder to eat. Thanks for sharing. Difficulties with memory and concentration, definitely. Right, so one participant saying harder to eat and another saying overeating, definitely. And something like sleep too, too much sleep, not enough sleep. Give another moment just to see if there's other comments. Thank you so much, everyone, for sharing so far. Okay. Oh, and lack of motivation. Thank you. Okay. Thank you, everyone, for sharing. I'm going to bring my screen up again here. Give me a moment. Okay. So it could be a long list, and what we have up on the screen here is certainly not exhaustive. And it's one of the really nice things about our job is that we also get to hear kind of the narrative and experience that patients have with something like depression. So there's no, perfect way of describing it. It can be experienced in a variety of different ways for different people. So really appreciate everyone sharing in the chat what that means for you. But up on the screen, we just have some examples of what that could sound like as well. So kind of along those lines of what we were talking about with CBT, those negative thoughts, and more specifically, we could have negative thoughts about ourselves, about others, about the world, and about the future. And these thoughts can maybe sometimes come up as almost like images in our mind or almost statements in our head, or again, maybe we also verbalize them. It could be something like, I'm no good, or no one values me, or things will never get better. When looking at emotions, we have our feeling wheel up on the screen here. Again, we could go on and on about the different emotions that somebody might experience. With depression, of course, feeling depressed or sad. Someone in the chat mentioned hopelessness. That's a common one as well. One might feel irritable or feel things like guilt or shame along with that, especially if it's been more difficult to do the things that you'd like to be able to do, have to stop working, etc. With regards to physical sensations, somebody in the chat shared walking through quicksand. We hear a number of those different kind of metaphors on the impact that depression can have on the body. Walking through mud, moving in slow motion, quicksand, because there can be that numbness or that heaviness to depression as well. There might be physical pain that's ongoing or kind of exacerbated by depression. Be feelings of tiredness or fatigue, just like was shared in the chat, and having low energy as a result. With regards to behaviors, there might be avoidance of certain things, people leaving the home, for example, isolation or withdrawal from other people, procrastination, knowing that I need or want to be able to do something, but that get up and go, that start is really difficult, if not feels perhaps impossible to be able to do. General inactivity, and perhaps even something like self-harm. So again, not a fully exhaustive list, but we can try to get an idea of how complex and depression can be. But as Hannah was also alluding to, this also provides us with a number of different opportunities to provide support and try to make some changes, including with the services that we have through our center. One final thing that I will mention as well, especially those emotions that we were listing off, very normal and common emotions to experience. So it's not like through our work we try to say, well, we're never going to feel sadness ever again. But it's more than maybe when we experience these things in excess more often than not, or they get in the way of what we need to be able to do. So sometimes when that might be happening, that might be that a sign that it's time to seek some help. So with that, I hand it back to Hannah to talk about some next steps.
Okay. Thank you all for participating in that discussion. And as Lauren noted, noting some common depression symptoms added to the chat, which I think speaks to some shared experience within the group today, and also strengths within everybody joining today to be coping with some of these challenges. So how to connect with our program. So if you resonated with the discussion regarding depression, maybe thinking about some of those symptoms, or have interest in the programs we offer, you may be thinking about how to connect with our program, whether that's for yourself or for a loved one, if you're not already connected. In order to connect with our programs, all patients need to have a referral from a physician, and we'll send everyone a link to our referral form following our presentation today. It can also be found on the Poul Hansen Depression Center website. At UHN, we have a centralized referral process, and our program is included as an option on the general UHN mental health referral form. For our program, patients need to be experiencing symptoms of depression or bipolar disorder. So we understand that depression can go hand in hand with other diagnoses or challenges, including anxiety, PTSD, ADHD, among others. And many of our patients also experience these. But for our program to be the best fit, depression symptoms are the primary area of concern and focus of treatment. And our program can also be helpful for support with clarifying diagnosis, psychiatry treatment recommendations, and the psychotherapy support that we mentioned. Along with our referral form, we'll send everyone a list of resources outside of our program that may be helpful to consider. And these resources will include crisis resources for in-the-moment care, connecting with somebody immediately if that feels needed and helpful, free walk-in counseling resources, some information about the free Ontario-wide Bounce Back program, other options for peer support, and the new OHIP-funded individual counseling available through the CAMH Ontario Structured Psychotherapy Program. And we'll also include information about the Connects Ontario directory, which is a free service offering information regarding mental health and addiction resources that can be used 24/7 and can be a good start if you or a family member needs support. You're not exactly sure where to turn. Thank you so much, everybody, for taking the time to join us today.